Well, welcome back to another week of our webinar. This time it's going to be on how to screen for obstructive sleep apnea. We're excited about that. And then stick around at the end because I'll be showing some housekeeping. We're making a number of improvements to the website and to the dashboard, and I want to show you those. But without spending any more time on this, let me go ahead and start the podcast.
Welcome back to the deep dive. We love pulling back the curtain on complex stuff. And today, we're really getting into something practical. It's right where dental care meets, well, your overall health. We're exploring this really powerful opportunity for dental professionals, especially dental hygienists, to screen for a condition you hear about a lot, but it's still hugely underdiagnosed: obstructive sleep apnea. So our mission today, pretty straightforward. We've got some valuable sources, some detailed guidance documents, some really helpful companion slides, and we're going to distill them, pull out the absolute essential knowledge you need on this screening process. Think of it as your shortcut to getting informed on why this is happening and like how it actually works.
And, understanding this isn't just academic. Obstructive sleep apnea, it's way more than just loud snoring. It's a serious medical thing. Yeah. Basically, the airway repeatedly collapses during sleep, stops breathing, and the knock-on effects, they're significant. We're talking direct links to things like hypertension, cardiovascular disease, type 2 diabetes, even mood disorders like depression and anxiety. So identifying those risk factors early, especially somewhere people go regularly, like the dentist, that holds immense potential for patient well-being, gets them on the path to diagnosis and treatment.
Okay, right. Let's unpack this a bit, because when you think healthcare screening, maybe your dental hygienist isn't the first person that springs to mind for something like obstructive sleep apnea. So why them? Why are they in such a unique, maybe powerful position to do this? What is it about the dental chair that makes it, an ideal place for this kind of check?
Yeah, that's really the core insight from the sources we looked at. There are a few key reasons the dental setting is kind of perfect. First, it's just frequency of contact. Simple as that. Patients often see their dental hygienist for cleanings more often than they see their primary care doc.
Yeah, usually twice a year, maybe more.
Exactly. So that gives you regular touch points, multiple chances over time to screen, maybe monitor risk factors. Second thing, and this is maybe the most unique advantage, visual access. I mean, dental hygienists are literally looking into the patient's mouth and oropharynx.
The exact spot.
The very area where the physical blockages causing obstructive sleep apnea happen. They have this direct, unobstructed view of the airway anatomy that most other healthcare providers just don't get routinely. And third, the actual steps involved in screening. They can be integrated pretty smoothly into the existing workflow, the standard recare visit.
Right.
It's not about adding some whole new disruptive procedure. It's more about incorporating specific questions, observations, maybe measurements into what's already happening in that appointment.
That makes a ton of sense. You're already there. You're looking in the right spot anyway, and you see them often. Okay, so if that's the why, how do they actually start this screening process? The sources seem to really emphasize starting with the patient's health history and a general physical look. What kind of red flags should a hygienist be asking about? Or maybe just noting from a patient's medical chart?
The medical history is definitely the starting point. Absolutely. Yeah. The guidance points to several systemic health conditions that are, strongly associated with increased risk. You'd want to look for a history of obesity or high body mass index, BMI. That's the measure of body fat based on height and weight.
Right.
Hypertension, high blood pressure, that's a major one, as is type 2 diabetes, cardiovascular disease, even chronic acid reflux, GERD, gastroesophageal reflux disease, that's listed as a potential link too. It's also really crucial to ask about depression or anxiety. These can be symptoms of poor sleep or potentially linked conditions themselves. And don't forget medications. You got to ask about those, especially any that might affect sleep or breathing. And family history, that's important too. If a close relative has obstructive sleep apnea or other sleep disorders, the patient's risk might be higher.
Okay, so that's the history, the stuff the patient tells you or is already in their record. What about physical things the hygienist can actually see or measure right there in the chair?
Right. The physical assessment adds another important layer of data. The sources highlight a few key measurements and observations. Neck circumference is a significant one. They actually give numbers. A measurement greater than 17 inches for men or 16 inches for women is noted as being associated with increased risk.
Wow, that's specific.
Yeah. And documenting body mass index, BMI, is also recommended because, like we said, obesity is a primary risk factor. And blood pressure, I mean, dental practices measure this all the time, right?
Routinely, yeah.
But it's worth emphasizing its relevance here. Hypertension isn't just a risk factor. It can also be a consequence of untreated obstructive sleep apnea. And simple observation matters too. Just looking at the patient. Are there visible signs of chronic sleep deprivation, like, dark circles under the eyes? Does the patient seem excessively tired or mention daytime fatigue during your chat?
And what about how they're breathing? Just sitting there in the chair. That
Yeah.
seems like a really direct observation you could make.
It is, yeah. While the patient's just sitting there waiting or talking, you can observe their breathing patterns. Are they mainly breathing through their mouth? Is their breathing audible? Like, can you hear it even when they're resting? Are there signs of nasal congestion or obvious blockage? These direct observations, combined with the history and the physical measurements, they start to build a picture of potential risk.
Okay, so you've got the history, the basic physical signs. How do you sort of quantify this, standardize the initial screening? This is where the specific tools come in, right? What questionnaires do the sources recommend using?
Exactly. To help stratify the risk, the guidance mentions using validated screening questionnaires. 2 are specifically referenced, the Epworth Sleepiness Scale and the S02a questionnaire.
Epworth and Stoppian. Okay.
The Epworth Sleepiness Scale, or ESS, gets particular emphasis. It's a really widely accepted tool. It basically assesses a patient's general level of daytime sleepiness. It asks how likely they are to doze off in different situations, sitting and reading, watching TV, that kind of thing. A score of 10 or higher. That typically indicates excessive daytime sleepiness, a real hallmark symptom of obstructive sleep apnea.
10 or higher. Okay.
And the sources make a really crucial point about the Epworth Sleepiness Scale. It's the preferred screening tool. Not just because it's validated and widely used, but specifically because it's mentioned by name with some pairs.
Ah, that's important. Practical.
Very practical. That detail can potentially help with reimbursement or just smooth out the referral process later if needed. So ESS is kind of the go-to. The SAPE's Bang questionnaire is also mentioned, especially in the slides. They note that a score of 3 or higher indicates a high risk.
And Bang is that acronym.
Yeah, it stands for snoring, tiredness, observed pauses in breathing, high blood pressure, body mass index, age over 50, neck circumference large, and gender male. Covers all those key risk factors we were just talking about.
Right.
But it's really important to remember, and the sources repeat this, these are screening tools only. They help identify people at risk who might need a closer look. They are absolutely not diagnostic on their own.
Okay, so they complement everything else.
Exactly. They complement the physical exam, the oral exam findings. They're part of the puzzle.
Right, makes sense.
Right.
They help gather more subjective info and point towards a potential issue. So beyond the sleepiness score from the Epworth, what other symptoms should a hygienist maybe be asking the patient about? Things they might be experiencing at home linked to poor sleep.
Good point. The questionnaire focuses on sleepiness, but there are other common symptoms to ask about, like, do they frequently wake up with a morning headache? Or a really dry mouth or a sore throat? That often happens with mouth breathing all night because the airway is blocked. Difficulty concentrating, maybe memory problems, feeling foggy during the day. Those are big clues due to that fragmented sleep. Mood changes, too. Increased irritability or symptoms of depression can be linked. Patients might even report restless sleep or insomnia, even though the root cause is actually apnea events waking them up slightly.
Interesting. Insomnia from apnea.
Yeah, and one that surprises some people, frequent nighttime urination. It can sometimes be a symptom because the pressure changes in the chest during apnea events can affect certain hormone levels. So all these little pieces, they add to the overall risk picture.
Okay, now here's where the dental professional's view gets really powerful, doesn't it? Unique. What specific things inside the patient's mouth and throat offer clues about obstructive sleep apnea risk?
This is definitely the home turf advantage for dental pros. They can directly see anatomical features that might contribute to airway blockage. They should be looking for things like a large tongue, macroglossia is the medical term, or visibly enlarged tonsils. Both of those can just physically crowd the airway space back there.
Right, taking a brim.
Exactly. The jaw structure is important too. A lower jaw that's significantly set back, that's called retrognathia, or one that's unusually small micrognathia. Both can predispose someone to airway narrowing because the tongue has less room up front, so it's more likely to fall back during sleep. A high arched palate can also be a sign. It might indicate a narrower upper airway passage overall.
Okay.
And the sources also mention looking for signs of bruxism, teeth grinding, things like worn down tooth surfaces or scalloped edges on the sides of the tongue.
Scalloped tongue. How does that happen?
It's often caused by the tongue pressing hard against the teeth, sometimes in a subconscious struggle to open the airway during sleep. And TMJ issues, temporomandibular joint disorders, are also noted as potentially associated.
Gotcha. Now, the sources specifically call out the Mallampati classification. Sounds technical, but seems important here. What exactly is that, and how is it used in the screening?
Right, the Mallampati classification. It sounds complex, but it's actually a really simple and non-invasive visual assessment. It just evaluates how visible the structures are at the back of the throat, the oropharynx. You just ask the patient to open their mouth wide, stick out their tongue. But crucially, without making any sound. No saying ah.
Oh, no, ah.
Because saying ah actually tenses and lifts the soft palate, which can artificially improve the view. You want to see it in its relaxed state. Then you classify what you can see into one of 4 classes. Class I is the best view.
Yeah.
You can see everything. Soft palate, uvula, fusses, those arches on the sides, the tonsil pillars. Class 2, you see the soft palate, uvula, and fosses, but the pillars are hidden. Class 3, getting more crowded. You can only see the soft palate and maybe just the very base of the uvula. And class 4, that's the highest risk category. You basically just see the hard palate at the front. The soft palate and uvula are completely blocked from view by the tongue.
Wow, okay, so class 3 and 4 are the ones to really note.
Exactly. A higher Mallampati score, particularly class 3 or class 4, is strongly associated with an increased risk of obstructive sleep apnea. It suggests the back of the throat is more crowded or the anatomy is such that it's more likely to collapse during sleep and block the airway. But again, like all these other findings we've talked about, it's just one piece of the puzzle. It's not a diagnosis by itself, but it's a significant indicator of risk.
Okay, so the hygienist has done the detective work. They've gone systematically through the medical history, the physical checks, used those screening questionnaires like the Epworth, done the detailed oral and airway exam, including the Mallampati classification. They've gathered all this data. What's the absolutely essential next step, especially if the screening is pointing strongly towards a high risk? I'm guessing documentation is, well, critical here.
Documentation is absolutely paramount. Non-negotiable, really, for several reasons. It creates a clear, objective record over time and allows for comparison at future visits. And it's absolutely essential for communicating your findings effectively if you need to refer the patient to another healthcare provider. So detailed and accurate record keeping using standardized terms is key.
And what specifically needs to go in that record?
Everything you found, basically. The medical history risk factors you identified, the results and scores from the screening questionnaires. Definitely make sure to note that Epworth Sleepiness Scale score. Record the Mallampati classification, class 1, 2, 3, or 4. Document your observations about the oral and airway anatomy, large tongue, big tonsils, retrognathia, etc. List the blood pressure and neck circumference measurements. And summarize the symptoms the patient reported experiencing at home, the headaches, the fatigue, the dry mouth.
Comprehensive.
Yeah, and the guidance even suggests practical tips like scanning the completed screening worksheets directly into the patient's digital chart. Makes it easy to find later. And maybe setting a follow-up flag for their next appointment just to revisit the topic or check if they followed through on a referral.
Okay, and if all those indicators do stack up, suggesting a high risk,
Yeah.
what's the process for actually referring the patient to get that definitive diagnosis and hopefully treatment they need?
Right, the referral process. First step is a really crucial conversation with the patient. You need to discuss your findings, but sensitively,
Yeah.
in a health-focused way. Explain that based on the screening, you're seeing some indicators that suggest they might not be getting quality sleep, and then gently educate them on the potential impact this can have on their energy, their heart health, their concentration, all that stuff.
So not diagnosing, just explaining the concern.
Exactly. The goal is not to say you have obstructive sleep apnea, but to recommend further evaluation by someone who can diagnose it. So you prepare a detailed referral letter. This letter is for a sleep physician or a specialized sleep center, and it needs to include all those screening results and observations you've carefully documented. Giving the patient some educational materials about obstructive sleep apnea can also be really helpful, empowers them to understand why this referral matters. The sources also specifically recommend considering referral to sleep medicine partners who offer telemedicine options. That can be huge for patient access, right?
Right.
It makes it easier for them to actually get that consultation and diagnosis.
My point. Removes the barrier.
For sure. Ultimately, the whole process is about getting the patient to a medical doctor who specializes in sleep. They're the ones who can order a sleep study polysomnography, make that definitive diagnosis, and then coordinate a treatment plan, whether it's CPAP, an oral appliance, or something else.
That initial chat, though, the chairside conversation,
Yeah.
that can feel tricky. It's great that the sources actually offer a sample script for that.
They do, and it's a really good example of how to approach it, gently, effectively. The quote they give is something like, "I'm seeing a few signs you may not be getting quality sleep, and that can affect everything from your energy to your heart health. Would you be open to answering a quick questionnaire so we can figure out whether a sleep specialist should take a closer look?"
Well, that's good.
Yeah, it's not alarming, right? Totally health focused. And it offers a clear, easy next step, just filling out a questionnaire. It frames it perfectly.
Yeah, that really does. Okay, this is all incredibly practical information for dental professionals who might be thinking about implementing this. You mentioned specific tools like the Epworth Sleepiness Scale and some kind of screening worksheet. Where can they actually find these resources? And maybe more info to get started.
The sources are very specific here, which is helpful. Crucially, they state that both the Epworth Sleepiness Scale questionnaire and a dedicated obstructive sleep apnea screening worksheet, which probably helps organize all these findings systematically, can be downloaded directly from the TDSS provider dashboard.
Okay, TDSS provider dashboard. Got it.
That seems to be the go-to place for the specific forms mentioned in this guidance. Beyond those specific forms, though, it's also really important for practitioners to just stay current. Keep up with guidelines from the relevant professional bodies like the American Dental Association and those joint guidelines from the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine. The slides also kind of hinted that other resources might be available, like quick reference cards maybe, or future blog posts. Suggests it's an evolving area, with ongoing support.
So, when you boil it all down,
Right.
what does this all mean? It seems remarkably clear, doesn't it? That dental hygienists, with their unique patient access, the direct visual perspective, and this ability to integrate pretty simple tools and observations, have this really significant, maybe largely untapped opportunity. An opportunity to screen for obstructive sleep apnea and potentially identify just countless individuals at risk who might otherwise just go undiagnosed for years.
Absolutely. That's the big takeaway. By implementing these screening protocols, dental professionals aren't just focusing on teeth and gums anymore. They're really expanding their role, stepping into preventative systemic health in a profoundly impactful way. Early identification through this kind of dental screening, it really does have the potential to change lives. It connects patients with the right medical diagnosis, gets them the treatment they need for a condition that honestly impacts so many aspects of their health, their quality of life.
It really makes you think. When you consider just how much time patients spend in that dental chair over their lifetime, and that unique direct view of the airway that hygienists have, how many cases of obstructive sleep apnea are just sitting there waiting to be identified? If this kind of comprehensive screening became truly routine, part of every single dental visit everywhere, what could that widespread implementation mean? Not just for individual patients, but maybe for public health on a much larger scale. It's a powerful potential. Definitely something to mull over until our next.
Ouch. That last little bit hurt. Please add any questions you might have about the webinar you just saw in the chat. And I'm going to go over a few things real quick. So first, with regard to the Epworth Sleepiness Scale versus like the Stop Bang, we recommend you use the Epworth because it is specifically mentioned by name with a few carriers. That is to provide medical necessity for referring to a sleep doctor. They don't always need that. And in fact, many cases, they don't even mention any type of a screening, but the ones that do mention the Epworth Sleepiness Scale. We also recommend that you refer, if you do not have a consistent, trusted referral source in the local medical community, we have one for you. And so what you want to do is you want to refer these patients that you screen and discover, refer them over to SLEEP, SLIIIP. And if you don't have that contact information, let us know and we'll get it to you. but they are going to send those patients back to you. They're not only are they going to send those patients back to you if they're mild, but if you have a reason for them to come back to you, if they are moderate or severe, talk to Dr. Denbar, because he has done in-service for that team of providers so that they know to refer back, even if it's a severe case, because they could have CPAP intolerance, or Dr. Denbar or you may have already talked to the patient about combo therapy, which frankly is the best solution for those. But that's why we recommend them. I can assure you that those patients will get referred back to you. I'm going to show you in a couple of minutes where to get the Epworth Sleep Scale and the OSA screening worksheet. And I'm going to show you some other things that we've got in a minute. On the newsletter, you should have gotten the most recent newsletter. Please let me know if you have any suggestions that you'd like to see in there. We're going to change the frequency of the newsletter to monthly. We'll probably make it a little bit smaller, but we want to get information out quicker. We're also setting up blog posts where you'll be able to access those, and we'll put articles up, articles that Dr. Denbar's written or I've written, or some that we find interesting and useful. We'll put that up for you. The study club is on July 10th, and I'll send out some more information, but you'll find it, you can read about it in the newsletter itself. We've done a major update to, or we're in the process of doing a major update to the dashboard. Some of it's been done, and I'm going to show you that right now. So let me minimize this screen. And so here's the dashboard, okay? And I just want to focus on a couple of areas here. The first one is, and before I do, let me say this. We're setting up for you another set of logins. So it's not the doctor's login that you'll be using. You'll be using your own login if you're a team member of one of our providers. We want to have the provider area separate because there's confidential information there. And then we want an area for you to be able to get to so you can access all of this information at your fingertips. So we're setting that up. That's one of the changes. But at the moment, let me just open up the documents and forms. So I'd click right here, and this screen would appear. I could do it, but I want to save time in the loading. And this is a revamp we've done. So you've got articles, handouts, practice packet. This is a new area, the TDSS Essentials. This is the practice management, and I'm going to show you that. Let me give you an example of how this works. You'll go in here and you'll click on the practice packet. And what it has in here is all of the forms we recommend you use. And we have good reason to recommend it, but you can go through these and look at them. And if you can read about the form, you can see an image, what it looks like. And if you want to download it, you just click on this PDF file and it opens up so you can download the form. Really good stuff. We're going to be updating those. This system we're using has version control, which means that if we update the form, you'll see that form has been updated. So I'm going to go ahead and close this. And I'm going to go back and show you the handouts that we mentioned a moment ago. And one was the Epworth Sleep Scale. So here's a copy of the Epworth Sleep Scale that we've got. And you can download it, use this, add your logo to it up here. However you want to use that. That's the one. The other one is the screening worksheet. So you can click on this and download this, add your logo up here. And so you've got those that you have access to. I'll show you something else kind of cool about this. Let's say you're not sure what folder it's under. You know, let's say you went to articles, there's an article in here, and you said, okay, well, wait, I want to get that screening form. So you can just type in screening over here, and it's going to narrow it down just to the screening forms that you're looking for. So that's another way to access the information in here. You'll see over the next week, you'll see a new folder called marketing material. That is the marketing material that I promised you in the last webinar. Our marketing team is finishing up that collateral. Those are going to be designed that you can download them, add your logo to them, your information, and then you can hand them out to the vet or to other people. It'll include presentations, PowerPoints that you can use, and we're going to include a video in there that you can take and just show to a Chamber of Commerce or some other group so you can get all the marketing material there. We've got the blog I mentioned, and then I want to show you the webinars. A couple of people have asked about that, and I think that's not it. I think I closed the webinar. Let me open it back up. Let me show you where it is. It's kind of easy to get to, but it's not a link at the moment. It's up here. It's called Home. You go here, Home Billing and Seminar. It will be a link in the next week or so. It's just not there yet. We don't want the general public getting to it. And then this is where the previous webinars are. Okay. Let me go back to the document library and show you the essentials. The only one that's in here right now is the one we just talked about. But what you'll see is probably by the end of the week, this first appointment advantage will be in there. And then the engaging the vet community will be in there, along with about 10 other documents. And our goal is to put the documents in there, the videos in there, any PowerPoints, any of that information so that you can have quick access to it. And let me think, essentials, all manuals. So I'll tell you something else. You can feel free when you get to these and they're all in here, feel free to go through them on your own. If you're comfortable with that, just go through them and